Good morning, everyone. I hope you're all doing well. It is 3:30 in the morning and I am so exhausted, but also really excited because today I'm going to be shadowing John, my fourth year roommate, on his trauma surgery rotation. So we're going to be spending a day at the trauma bay, hoping to learn a lot. So looking forward to a good day. How was that for you?
That was pretty good.
Oh my
It
God.
was nice and fresh. How was it for you?
I'm dying.
Damn, this is the best part of my day.
So good.
This is our local maid for the house. And also my girlfriend.
Sorry guys, John is taken.
Yeah.
And sorry guys, Danny's taken.
and we make a mean avocado toast.
You do indeed.
One thing we didn't talk about is Danny's actually the biggest fan of Yak's channel. She once got mad at me because I watched an episode without her. So we just finished rounding, and the kind of order of the day, at 6 o'clock we got in and we got the sign out from the night team. We ran through the entire list of about 15 patients and they updated us on kind of what the plan was, anything that happened overnight. And then from there, Yakov and I picked one patient to see who we're going to present to the attending. And which that'll be at 7:30.
So we just finished rounding on our first patient. She was a super sweet lady who came in with some orthopedic complaints, several fractures, but looking into rehab options for her.
Yeah, despite the injuries, her spirit is kind of out of proportion to the level of her
Which is
industry,
always
so
nice
I
to
would
see.
say, yeah.
So for those of you watching at home, John, what does rounding mean?
Rounding is essentially comes from back in the day when you used to walk all the way around the ward of the hospital, going from room to room to check in on patients. So essentially rounding is checking in on patients. It typically consists of just following up on any issues overnight, first check to make sure there are no acute events, and then seeing if there's any new ones that are occurring, and then just to do a general physical exam, get a good picture of them, checking, of course, their chart, vitals, and any other things that might have happened overnight, which we will then present about when the attending comes. All right, so it got pretty hectic in there and we didn't have time to do our usual discussion of a case right after. So we're here back in Yak's room and just wanted to go through and discuss kind of how things went there. And so Yak, what was it like to go through kind of one of your first trauma experiences?
Yeah, no, this was my first experience with a true trauma and actually getting involved. It was really amazing just to see how quickly everyone jumped into their roles. Everyone knew exactly what their responsibilities were. And it was really cool to be on the inside of all of that as opposed to just sort of watching it. I feel like to the average person it would look like utter chaos.
Right.
But what I didn't realize was how organized it actually is. Despite the loud noises, despite the fast movement, everything was very, very organized.
Yeah, and so to discuss some of that workflow, at the head of the bed is the airway team, which is usually an emergency medicine physician who comes from the blue team, of which we were formerly one of the bad boys in blue. And they come over and run the airway. Moving down towards the feet, the next on either side, you have one of the trauma nurses and the chief resident who's actually running the primary and secondary survey, shouting out any of their findings that they have. And then kind of moving down towards the feet, it's usually some of the other residents, med students who are there to help, get clothes removed so that they're, clothes removed so you can do a full exam. And then the most important person, the conductor of this whole ensemble, is the trauma surgeon. And so he's standing at the foot of the bed, looking and observing everything, listening to anything that the chief resident is pointing out on the primary or secondary survey, and kind of synthesizing this, and then directing the whole orchestra about where to go from there.
So in terms of the specific case that came in today, it was 2 people who came in after a motor vehicle collision. One patient lost consciousness and the other didn't. So John, what are some of the things that you worry about with a motor vehicle collision?
Yeah, first and foremost, with the loss of consciousness, you worry about the possibility of a brain bleed. If any of the vessels are torn, the brain is inside of an enclosed case of the skull, and so any bleeds can lead to compression of the brain itself. So that's one of the first and foremost things we look for is checking their status of cognition and to see if they have any of the neurological signs that might indicate a brain bleed.
Right. And what are the ABCs associated with a primary survey?
Right, so that is the definition of a primary survey. When that patient first comes in and they take them from the gurney to the actual bay table, that's the first thing that they're assessing for is their airway, making sure that they're breathing and that they have a good tract to be able to bring oxygen in and out of their lungs. B for breathing, making sure they have bilateral breath sounds, and C, circulation, which kind of the biggest indicator that we get is the blood pressure.
Right.
And then once those are done, then we move to the secondary survey, which is essentially a head-to-toe exam, looking for any injury to the limbs, extremities, or to the chest or the abdomen. So that was it for the first trauma of the day.
Yep. And now back to the hospital.
Yeah. So now we're off to see one of our patients on the floor to do a tertiary survey. So when they come to the trauma bay, we do our primary survey, airway, breathing, and circulation, followed by a secondary survey looking for any other visible wounds. And then about 12 hours later, we'll do what's called a tertiary survey and look for if there's any other last kind of injuries that we might have missed in the trauma bay or that haven't kind of made themselves known until now.
Yeah, so we'll let you know how that goes in a bit.
Yeah. So we just got done doing the tertiary exam on our patient. One of the aspects that made it difficult was, the patient's history with mental illness. And one of the kind of components of that can happen that we see from time to time on the trauma service is an involuntary admission to the psych ward. In the state of DC, it's a form called an FD12, which essentially they're a danger to themselves or others.
Right, and that might sound inhumane, the idea of involuntarily admitting someone, especially to a psychiatric ward, but at the end of the day, if it's your role to heal, which that is our role, if they're a harm to themselves or others, it's the only moral thing to do.
Yeah.
And so it's tough, but that's the reality you sort of face.
Yeah. So our first patient for the day in clinic survived multiple gunshot wounds, some of which were to the head. And despite this, just the location was fortunate enough that it didn't hit any bones, no major nerves, no major vascular structures. And so we're just really curious to see what he's looking like on follow-up.
Yeah, so we're gonna check in on him and let you know how that goes. Okay, so we just finished seeing our patient with multiple gunshot wounds, and amazingly, he's doing really, really well.
Had it been like an inch closer to his head, he probably would have been non-survivable.
Okay, so that's it for today's video and our rotation on the trauma service. I hope you enjoyed it. Be sure to hit that like button and subscribe, and leave a comment down below. I'll be sure to reply. Another thing we should mention is that John is going to be starting his own YouTube channel.
Yeah, I was traveling for 3 months and just took videos all the way through. So I'll take you along for the ride.
Absolutely. Until next time, bye-bye.